Hi, I am Sreekala, working in Regional Cancer Center, Thiruvananthapuram. Today, I am trying to say about brachytherapy. Before coming to the topic, I would like to thank the organizers for giving me a chance to present this here. Role of IGBT, image-guided brachytherapy, in treating uterine cancers is my topic. We know radiation therapy is broadly classified into teletherapy and brachytherapy. Teletherapy is otherwise called external beam therapy using ionizing radiation, mostly X-rays. It refers to the delivery of high-energy radiation beam from outside towards cancerous tissue. Brachytherapy is a type of radiation treatment in which sealed radioactive sources are arranged in such a fashion that radiation is delivered to the tumor at a short distance by interstitial, intracavitary or surface application. Coming to the evolution, brachy, a Greek word, means short distance, was proposed by Fossel in 1931. Radioactivity was described by Becquerel in 1896. Marie Curie extracted radium from pitchblende ore in 1898. Danlos and Bloch performed first radium implant in 1901. Radium and radon were the two radioactive sources used in early years. Cobalt-60, cesium-137 and iridium-192 were used for brachytherapy in 1940 to 1970. Cesium-137 began to replace radium-226. Henshay introduced afterloading techniques using iridium-192 in 1953. LDR brachytherapy became the gold standard in 1953. Rules for implantation were made in 1940s. In 1970, Selectron LDR remote afterloading system was introduced. HDR became widely accepted in 1968. Then comes PDR. Then comes image-assisted HDR with X-ray simulation. Now, with more sophisticated imaging hardware and software, image-guided brachytherapy is being done. Advantages of brachytherapy. A high localized radiation dose to a small volume which leads to higher local control. Spares surrounding normal organs and tissue due to rapid dose fall-off. Ultimate form of conformal radiotherapy is brachytherapy. Comparatively, it needs a shorter treatment time. Non-homogeneous dose distribution to tumor for getting the hypoxic central core. There are some disadvantages also. It's invasive, time consuming for patient preparation, needs expertise, experience and equipment. Difficult to maintain uniformity across various centers. Brachytherapy can be classified according to type of application: intracavitary, interstitial, surface application and intraluminal. It can also be classified according to dose rate: ultra dose rate, that is 0.1 to 0.3 gray per hour, low dose rate 0.4 to 2 gray per hour, medium dose rate 2 to 12 gray per hour, high dose rate greater than 12 gray per hour with iridium-192, pulse dose rate 12 gray per hour with iridium-192. Here the dose delivery is in pulses, 10 to 15 minutes every hour. Then image guided brachytherapy. Actually, this is a volume based brachytherapy. The various steps involved in this procedure are pre-implant evaluation, applicator selection, imaging, delineation, prescription, treatment planning, target dose specification, treatment delivery. Coming up one by one, pre-implant evaluation. Patient should have a detailed gynecological examination, assesses the anatomy, residual tumor and decide brachytherapy applicator best suited? There should be appropriate medical examination and instructions should be given such as bowel preparation, bringing of lab reports, etc. Applicators. Various types of applicators are available. Tandem and ovoid, tandem and ring, tandem and cylinder, tandem, ovoid or ring with guides for interstitial needles or tubes. First comes tandem and ovoid. These are most widely used applicators. It consists of an intrauterine tandem and two ovoids. These are of various dimension. We can select according to the anatomy of the patient. Then tandem and ring ovoids. These are used for patients who have shallow vaginal fornices. Then comes tandem and cylinder. These are for patients with upper vaginal stenosis or disease involving lower vagina. Tandem and ovoid or ring with guides for interstitial needles or tubes. These are for patients with large bulky tumors, needle tubes to shape, fine-tune and enlarge the treatment volume. In addition to this applicator, we can use hollow needles for interstitial application. Applicator insertion. Tandem and ovoid, tandem and ring or tandem and cylinder for intracavitary application inserted freehand. Hollow interstitial needles are inserted either freehand or with templates. Then comes imaging. MRI or CT is done to obtain measurements of tumor size, volume and extent of disease. This aims at localization of the source position, to localize the target, to localize the organs at risk, to determine the relationship between these. CT imaging. A plain CT is obtained after applicator insertion with 3 to 5 mm cuts. This aims at verification of proper placement of the applicator, reasonable estimation of the location of the uterus, visualizing bladder and rectum, analyze 3D brachytherapy dose distribution, 3D dose calculation and optimization possible. Then comes MR imaging. This aims at multiplanar imaging, excellent soft tissue contrast, visualization of tumor and parametrium involvement, to differentiate between uterus, cervix tumor, other pelvic tissues, OAR contouring, organ wall may be clearly visualized. Delineation. The target volume and normal tissue structures are delineated on images in TPS. This is performed at the time of each brachytherapy application. Treatment prescription. This should consist of target, target dose, dose rate, dose per fraction, fractionation plan, applicator type used, type of afterloading, description of additional interstitial needles if any. Treatment planning. Treatment planning and dosimetry should be performed every time applicators are inserted to assess doses to the target and normal tissues. Target dose specification, dose limit to critical organs, OAR specification, catheter reconstruction, source loading pattern. Here, radioactive source used is iridium-192. Iridium-192 is a man-made radioactive isotope produced from non-radioactive metal iridium-191 in a nuclear reactor. Its half-life is 74 days, produces gamma rays of average energy 0.38 MeV. We can see the source structure. Actually, it's a small cylindrical wire with length of 0.35 cm and diameter 0.06 cm. This is encapsulated in a steel capsule. We are treating this using this equipment called microselectron. We can see the transfer tubes connected to the indexer. This is the structure of microselectron. We can see indexer face with 18 source channels and transverse tube are connected. The proximal end to these holes and the distal end is connected to the applicator. This is the treatment console used for treating. Finally, treatment delivery. After all these procedures, patient is shifted to HDR treatment room. Treatment plan sent from TPS can be imported here. Transfer tube are connected to the applicators according to the plan. When treatment option is given, one single source is transferred to the planned dwell position in the applicator and the dose will be delivered. Thank you.